I've asked all of my surgeons that are doing type A dissection surgery to get trained in this. And, you know, it will take a couple more years before we know for sure, but the initial data looks good. And I would like it to be standard of care in patients without aortic arch tears.
It's similar scenario here in Berlin. So now it's the kind of routine treatment for the type A dissection, the acute ones, excluding, as Michael was pointing out, those with a primary tear in the arch, especially if the tear is in the distal arch. Otherwise, as we discussed a minute ago, we could do it zone 1 or so anastomosis. I would personally, my personal opinion, and it's also in reference to the next question, I'm a little bit reluctant to use it in very young patients where there is suspected connective tissue disease. Usually those patients are typically, I mean, if they are stable and if they are not in deep shock, then I think those people should have a full arch eventually plus a David proximal. And this is definitely kind of a more complicated procedure where, at least this is our strategy, we would call those people who are familiar doing it. I think it's the same situation, Michael, right? A young 25-year-old suspected Marfan, you would do the whole thing.
Yeah, stents should be generally avoided in those sort of patients. I agree with you completely.